afternoon, everybody. So I'm Saket Priyadarshi. I'm the Associate Medical Director for Addiction Services across Greater Glasgow and Clyde Health Board. But I'm here in my capacity as the chair of a short life working group that has been asked by the Glasgow City Alcohol and Drugs Partnership to develop a business case for safe injecting facilities and a heroin assisted treatment service here in Glasgow City. The idea being that that business case would then be taken to the Integrated Joint Board, which is the decision-making body for Glasgow City's Health and Social Care Partnership, to decide whether it's something that the city would want to progress in the near future. So the fact that you haven't all had a sharp intake of breath and fallen off your seats at that shows that that's actually a matter of public record. Yeah, it's something that the ADP announced to the media and publicly at the last ADP strategic meeting a few months ago, and we've been working away in the Short Life Working Group to progress the work that we've been asked to do, and I'm going to talk about where we are with that at the end. In between my long rambling introduction and my end, there will be the substance of our presentation, which is through Mark, my colleague here, Mark Rodgers from Public Health, who will take you through the report called Taking Away the Chaos, which was a health needs assessment of public injectors, people who inject drug in public places in Glasgow city centre, which has really recommended some actions, and it's some of those actions that we're progressing now through the Short Life Working Group. But before I go any further, first of all, I want to thank the chair for the introduction and for the Scottish Drug Forum to organising this event today. Fantastic turnout, and I'm really impressed that so many of you have stayed on for so late in the day. Many thanks to our visitors from overseas, not just for their input today, but a small group of our Short Life Working Group colleagues had an opportunity to meet with them yesterday and spend time and pick their brains in a bit more detail about the services they provide in order to give us guidance and help our own work develop and progress in the Glasgow context. I also want to just thank Kirsten in particular for the work she's been doing since returning from the Churchill Scholarship, which was time well spent, I think, and your focus and drive in support of the needs of probably the most vulnerable and marginalised group of people in Scotland is much appreciated. So I want to, in background, talk about Glasgow a little bit. And I want to say that I think, as a resident of Glasgow, Glasgow's a great city to live in. It's a thriving, exciting, international city. It's modern, it's cosmopolitan. Did you know that Glasgow has the highest GDP outside of London in the UK? It has a financial and business sector that is thriving. It's got a retail industry that people from all over come to take part in. The city centre offers excellent amenities for those who are on reasonable incomes with secure employment, and particularly music, fine arts, drama. And the great thing about Glasgow is the Loch Lomond and all these other sort of countryside and amenities are just outside in easy distance now. Most of you know this, but I'm thinking about the doctors we need to recruit for our future services. But you know, we should be really proud of the city, quite rightly. I think it's really transformed from where it was 30 odd years ago to where it is today. 3 big universities, a school of art that is world renowned, a thriving creative industry sector. And yet yesterday as I was walking, you knew there was a but coming, didn't you? You knew there was a big but coming. But this isn't the big but, by the way. This is just a preamble to the but. So yesterday, as I was coming in to meet our visitors from abroad, I had that same sort of sense of anxiety, partner anxiety that I have whenever I have visitors in Glasgow, which is, which Glasgow will they see? You know, the Glasgows of their preconceptions, or the Glasgow, the modern Glasgow that I've described. And, you know, I'm just reflecting on that today. What we've heard is actually all international metropolitan cities have problems, have similar problems. Glasgow is a metropolitan area for 2.3 million people, and we seem to share the same problems that Sydney, King's Cross area in Sydney faced, that Dublin is facing, that we know exists in Vancouver, Toronto, Baltimore, New York, Bilbao, and Madrid, which are two of my favorite European cities, all across Germany, all across Scandinavian countries as well. I think what we should take out of today is that actually these are problems of international, modern, metropolitan areas. Yeah? And we should also take out today that other countries have begun, other countries are well down the route of dealing with these problems, as we've heard from Zurich's example, and other areas are developing solutions. And so that should give us the confidence to be progressive around what we need to do here, because we do have problems. Within 10 minutes of walk from here is this public injecting site located right in the heart of Glasgow city centre. And you can see needles, some with blood still in them. At the site, there's alcohol, there's volatile substances. We think this is used by about 6 to 8 individuals. We know those individuals. Our assertive outreach team knows those individuals. I'm not going to show you the other photos from this site, but it tells you that people are sleeping in that site, toileting at that site, and using vast amounts of polysubstances here. And there are multiple sites like this in walking distance from where you are just now. We have been involved with responding to issues raised by public injecting for a number of years now. You're going to learn more about the public injecting population in Glasgow city centre shortly from Mark. But just to say, you know, in this room are many people who have contributed to things like picking up discarded needles, trying to help engage people who are public injecting Glasgow city centre with treatment services, the liaison work we've done with police and others. But until last year, it was really quite a niche interest for a few of us, and not something that was, and I don't mean to overstate this, but this is my experience, and that it wasn't really something that was part of central planning around the NHS or the Health and Social Care Partnership, until we had new cases of HIV in drug users in Glasgow in 2015. So we had 47 new cases in 2015, and we would usually expect 5 to 10 cases a year. When we did some interviews with the HIV positive individuals, we found that most of them, 83% of them, were actually injecting publicly, some frequently, some occasionally, and injecting publicly in Glasgow city centre. And at that time, our public health colleagues, so Katrina Milosevic is the lead for the HIV incident management team, and Dr. Amelia Crichton there, who was at the time the acting Director of Public Health for Greater Glasgow and Clyde, became closely involved and really led the work around conducting a full health needs assessment of people who inject drugs in public places. And it's the result of that health needs assessment that we have the recommendations that we have to go and explore the option of safe injecting facilities and heroin assisted treatment. But of course, as was mentioned earlier, this population has been vulnerable to a whole range of problems, drug-related deaths, anthrax, botulism outbreaks recently. And we've had, those of you who work in the homelessness sector and the criminal justice sector will know this population from your own experience of them, which is that they're frequent attenders to our prisons, to our custody suites. They go through our emergency housing accommodation and often end up back out in the street, because there's that issue of effectiveness of meeting complex needs. And so just bear that in mind, because that was something we wanted to explore as well. And we have been getting a lot of concerns from members of the public, from businesses, from elected members, quite rightly saying, you know, what's happening in the city centre? What is the response to discarded needles in back of people's clothes, outside businesses? And so we have taken that into account as well in the work that the public health colleagues did around the health needs assessment. So Mark, I'm going to hand over to you, and I'm going to come back to discuss taking forward how we're taking forward some of the recommendations.
Thanks, Saket. So I'm just going to be describing some of the nuts and bolts of the needs assessment. Essentially, it was composed of 3 different parts. The first was the epidemiological element, in which we tried to gather as much information as we could to inform our understanding of the health needs of this population and their characteristics. This involved lots of local data, and we collected it from Scottish Ambulance Service, local authorities, Glasgow Addiction Services, and we complemented this with international evidence through the form of a series of literature reviews. The next section was a comparative element, in which we looked to compare the current service provision available in Glasgow to that in other parts of the UK and abroad. That involved gathering data from a number of different services, and I've just got a short depiction of Glasgow Addiction Services as they stand, ranging from low threshold Tier 1 services through to high threshold Tier 3 and Tier 4, such as specialist residential rehab facilities and caseworkers, and this is predominantly run through the 9 community addiction teams in the city. Generally speaking, the quality of service available in Glasgow is very high quality. So we look to compare this service to that in other cities that have experienced similar public injecting problems. Next was the corporate element, or the stakeholder consultation, which several people in the room were actually part of. Here we look to gather feedback on the public injecting issue from individuals currently involved in injecting drug use through a series of one-on-one interviews, individuals in recovery from injecting drug use through a focus group, and staff and service providers. We got their feedback through an online questionnaire, which we got 33 responses. So what did we find? One of the first things that became apparent is we don't have a very good idea of the number of people involved in public injecting in the city. Drug use is highly stigmatised, public injecting particularly so it's not something that's regularly collected through existing data sources. But despite this, we were able to pull together information from a number of different sources and arrive at an estimate of between 400 and 500 people who we believe are injecting in the city centre in public on a regular basis. And we're quite confident in that estimate, as it ties in really closely with the sort of numbers known to the Assertive Outreach team, a service that's specifically designed to engage with people using drugs on the city streets. We were also able to establish quite a good demographic profile for these individuals, in which we found them to be predominantly male, of Scottish origin and aged between 30 and 50. Again, this is characteristics that overlap very closely with the individuals affected by the recent HIV outbreak. We also found that homelessness and recent incarceration was prevalent amongst the group. Next, we tried to really establish why public injecting was occurring in Glasgow and what was driving it from a local perspective. And a number of key themes emerged that was backed up from the literature that we collected. The first of them was immediacy. People were looking to inject their drugs soon after acquiring them as possible, and this was driven by 2 factors in itself. Firstly, people were unwilling to travel with their drugs for any length of time for fear of being robbed and fear of being arrested. Also, the demands of their addiction means that they simply couldn't wait. They had to take it as soon as they got it. We also found that many of the individuals involved in injecting in public places simply didn't have an alternative. They're either homeless or unstably housed, staying in hostels which strictly forbid the use of drugs in the premises, so they simply didn't have an alternative but to take to the city streets to inject. But it's important to remember not everybody involved in this was homeless or unstably housed. Some individuals actually perceived public injecting as being a safer alternative, and they were more likely to get help in the event of an overdose than they would in a private space. Other people simply wanted to keep their addiction secret from their friends and family, so simply injecting at home wasn't an option. The next thing we tried to really understand is where in the city public injecting was occurring. And as you can see from this map that we've pulled together from local authority data on the levels of drug-related litter in the city, we see a real hive activity around the south-east quadrant. For those that know Glasgow, it's an area from the Tronggate through towards the East End towards Carlton. The sort of areas within that people were found to be ejecting were car parks, public toilets, closes, alleyways, and even makeshift drug consumption huts. The reasons these locations were sought out were very simple, and we've got some quotes from our stakeholder consultation to highlight that. People simply wanted to get a degree of privacy in the process. They're also looking to get out of the exposed elements. Also, people were looking to get access to some of the resources required to inject, as highlighted by this third quote here, just to get access to running water. So public toilets were a common place where people were looking to inject, especially restaurants in and around the city centre. If we take a close-up look at one of these locations, we see the sort of unhygienic environments that people are being forced to inject in. This is an area of waste ground just east of the city centre, well known to local authorities. It's cleaned up on a regular basis, after which the drug-related litter rapidly accumulates. So it's clearly being used by more than one individual on multiple occasions. Now obviously locations like this present a real health hazard to members of the general public, but injecting in these locations also creates specific health hazards to the individual, on top of the inherent risks that public injecting drug use carries with it anyway. And again, we've got some quotes from a stakeholder consultation to highlight that, but predominantly they relate to the speed at which people inject in these environments. It's not something they want to take their time over. They might get caught, they might get interrupted by the police or a member of the public. The whole process is characterised by haste. Also, in injecting in very exposed environments, particularly in Scotland, means that people are exposed to the elements. Times it can be quite difficult to find their veins and seek out groin injection, which carries with it an increased risk of arterial injury. Also, injecting in these kind of locations, the preparation process people go through is very quick. Again, they don't take their time over it. All these factors combine to mean that the likelihood of injection-related injury occurring through public injecting is much higher than other forms of injecting drug use. This means people are more likely to need medical attention, increasing their time and resource impact on acute services. We also found in this population that there was a number of barriers to better health, and health was considered a very low priority for a number of different reasons. The first of them was simply the demands of the addiction itself, but as well as more basic needs such as being homeless or having housing problems, poverty, all were seen as barriers to achieving better health. We also noted that in our stakeholder consultation there was quite a fatalistic attitude towards health for people involved in injecting drug use. They thought, why should I care about something that's going to affect my health in 5 months or a year or 5 years when I might die of an overdose tomorrow? So, pulling all this data together, we arrived at some four key health needs for this population that we would look to address in the future. The first of them is in relation to their addictions care. Generally speaking, the evidence we collected shows that public injecting is associated with a higher level of dependency than other forms of drug use. And despite the services available to addictions in Glasgow being considered of very high quality, there are still areas for improvement, particularly in relation to person-centred care and applying some of the interventions that we heard about earlier in a Glasgow context. Another key health need was in relation to bloodborne viruses. The communal injection and sharing of needles that characterise public injecting for some naturally carry with it an increased risk of bloodborne viruses. This is something we saw in the local context that was backed up by wider evidence, and addressing this is something we need to do in the future, particularly in relation to the recent HIV outbreak in the city, but it also extends to the Hepatitis C. On that note, we also had other injection-related injuries and infections. Again, a series of infectious disease outbreaks have hit this population stretching back over the last 15 years, and unless changes are made, that is likely to continue in the future. It's inevitable. And the last key health need we identified was in relation to overdose and drug-related death. We didn't have a huge amount of local data on this, but relatively speaking, the levels of drug-related death in Glasgow are higher than other parts of Scotland. In addition, the speed at which people inject carries with it an increased risk of overdose, so for that reason we characterise it as another key health need of the population. So pulling all this data together, we tried to establish what could work in the future to try and improve the health of the group. And the first thing we arrived at and looked at literature on was safe injecting facilities. I appreciate you've heard an awful lot about this today, so I'll keep it very brief, but as we know, it's facilities where people can take their legally obtained drugs and inject in a safe, clean and hygienic environment. And the benefits for this are clear, helping to use sterile injection equipment, advice on injecting technique, assistance in the event of an overdose, and also as they're co-located with other services, it helps link people into them in the future and improving their health. When asked about this, well, although these sites aren't obviously present in the UK just now, they're throughout the world, particularly in Europe, Australia and Canada. When asked about stakeholder attitudes towards the possibility of introducing safer injecting facilities in Glasgow, the responses were overwhelmingly positive for a number of different reasons. The first of them was from the safety aspect. People saw it as a safer alternative, getting people off the streets into services, even if it was just a very basic, just to inject and relieve. It would help improve their health in the future, and it was highlighted as a key benefit of these in a Glasgow context. There was also benefits noted by many members of the clinical staff as part of our stakeholder consultation in relation to improving bloodborne virus care and relationships with patients. This is something that would allow a safer injecting facility to engage hard-to-reach populations amongst the community, and this is particularly relevant in the HIV outbreak that we find ourselves in. By members of our stakeholder consultation was that it would be perceived quite well by members of the community, particularly businesses who have had their local environment affected by public injecting in one form or another, or through needle-related litter. So it was seen as really positive aspect for the community and not just the individuals whose health would be improved by attending these facilities. But despite this, a number of negative aspects were noted by our stakeholders, and it's important to note them too, particularly in relation to the cost of facilities, which, as you can imagine, are pretty expensive, but also into how it may be perceived by members of the community if it was seen to affect a honeypot effect, as Kirsten mentioned earlier, drawing people to an area if there wasn't already a drug problem, and that was a fear that was noted by a number of stakeholders. The next intervention that we looked at was in relation to heroin assisted treatment. Again, some of you have heard quite a lot about today, so I'll keep this fairly brief. But unlike safer injecting facilities, this has been used in the UK on a pilot basis with lots of benefits registered, particularly in relation to the health of individuals. Community benefits in terms of creating stability in people's lives and helping them engage, improve their social functioning, and also from a cost-effective perspective, it proved a much more effective treatment than the methadone programme, despite it being initially cheaper. When asked about this, again our stakeholders displayed largely positive views towards the introduction of a heroin-assisted treatment programme in a Glasgow context, particularly in relation to impacting the illegal market of heroin. It was seen as a much safer option, and it would have a lot of community benefits as a result, as highlighted by that first quote here. The second aspect that was registered as benefits from a lot of our stakeholders is that it would provide a really enhanced option for engaging people in addictions treatment. They may have had negative experience with the methadone programme, something didn't work for them and they've disengaged as a result. This will be able to get these hard-to-reach individuals back into services and would provide a real benefit. The last benefit that I've chosen to highlight here was in relation to providing a greater need of stability in individuals' lives, improving their social functioning and helping them move on with everything that's around them. This idea of taking away a chaos that we use for a title, this was a key benefit that was highlighted by a number of our stakeholders. But like SIFs, a number of negative aspects were registered, particularly in relation to the cost, which initially is more expensive than the methadone programme, and how such a move again would be perceived by the public, and there was real fears about that from a small minority of our stakeholders. The last intervention that we looked at that can maybe be applied in the Glasgow context is extending IP coverage in the city or injection equipment provision. We look to do this in a couple of ways, either creating more fixed IP outlets with longer opening hours or through the form of vending machines such as pictured here. This is something that's commonly applied in Europe as well as some parts of Australia and New Zealand. The idea is you obtain a token, you can go up to the vending machine, you get your clean noodles and you can dispose of the dirty ones in the bin provided. The benefits for extended IP are clear. They help induce better injection practices, more hygienic, and is beneficial in preventing bloodborne viruses and essentially reducing the risk. The evidence for vending machines is a lot more limited, but some evidence from the literature search showed that they help engage a more vulnerable user group, individuals who are perhaps fearful of attending manned IP outlets. When asked about this again, our stakeholders displayed positive views towards extending IP coverage in the city, particularly in relation to out of hours access in the city centre, and they feel there may be gaps in that, particularly through the hours of the night. Other benefits that were noted by, although the extending IP coverage was seen as a real benefit, there was downsides in doing this through vending machines. and many members of the staff preferred the manned outlets in the way that it gave opportunities for signposting and clinical intervention in the form of harm reduction, so they much preferred extending IP coverage but through manned outlets. A number of negatives were also noted in relation to this in terms of cost and duplication of efforts, and so this was something that again was brought up in the stakeholders, but overwhelmingly positive in extending manned IP outlets across the city. So hopefully that gives you an idea of the sort of work that was carried out as part of the needs assessment, where we got our evidence and some of the conclusions that we came to. It's clear that the health and social care needs of the population of people who inject drugs in public places are multiple, complex, and hard to disentangle from social vulnerabilities, particularly in relation to homelessness. This is why we feel we need to apply the international best practice in a Glasgow context to address these issues in the future. In light of that, the report has made a number of recommendations, many of which you already know quite a lot about. Some targeted at current services, some targeted at the introduction of novel service into a Glasgow context, and Saket's going to just briefly talk through those recommendations with you.
At this point, just to acknowledge the work that Mark Rodgers and Dr. Emily Tweed, who can't be here with us today, have done. They're the main authors of what I think is an excellent report. And I'm not just saying that because I chaired the steering group that produced it, but these two put a huge amount of effort in very quick time in looking at the data, meeting the stakeholders, conducting interviews, etc., and writing up their reports. So well done, Mark. That was an excellent presentation as well. So the recommendations and the challenges that they've made to us is, in terms of service development, we have to try and meet complex needs of these individuals beyond addiction and blood-borne virus care. So that particularly includes, it's recognising the literature around severe and multiple disadvantaged people, and how we engage and get most effective outcomes with them. And so we're working through the HSCP, which has given us a real opportunity to work together intersectorally with homelessness, with criminal justice, with our voluntary sector colleagues, with our commissioning teams, to look at how current service provision can in the future best meet the complex needs of this population. Our recovery communities in Glasgow, as you know, have really flourished over the last 7-8 years or so, and we've got a fantastic recovery community across the city for people who've worked their way through into early, mid, late recovery. But for those people who are really not there yet and not able to enter that recovery, we don't really have an active peer support network and advocacy group as we would like. And so we are thinking about how best to progress that, and then we'll have had conversations with some of you in the room about next steps as far as that's concerned. It's kind of a difficult one, isn't it? Because you want that to come from the groups, but sometimes it requires a little bit of development time to seed and assist that. So we're looking at options. As far as our services are concerned, particularly our drug and alcohol services are concerned, you know, what else could we be doing in terms of meeting the needs of this population? And you heard John Strang describe, you know, gold standard opioid replacement therapy, for example, optimal dosing, engaging. You heard Thilo describe low threshold, really person-centered care. And I think these are things that we are working with our homeless health services and community addiction teams in their development to see how they can contribute. The injecting equipment provision, there were some queries, that some evidence arose that there was perhaps a gap in injecting equipment provision out of hours. Glasgow is the only city that has a 24-hour IEP provider, but that's located perhaps in a part of the city centre that is far enough away from the scene of public injecting to be not sufficient. And so John Campbell, an injecting equipment provider, manager for GG&C, has been working with providers in the city centre to see how we can meet, plug that gap. But doing all that, you know, the evidence strongly suggested that even doing all that would not necessarily meet the broader needs of this community, and therefore there were recommendations about new services, particularly around piloting a safe injecting facility and piloting heroin assisted treatment. I'll come back to them shortly. But the other recommendation that the authors made was around, we should be routinely gathering data on public injecting, so that can inform our future work around this. In terms of the two recommendations, number 5 and 6, as I said, the Glasgow ADP has asked us to now progress this. We have a short life working group, which is a large group of 25 different stakeholders from different backgrounds, different services. We can't get everybody would like to be a stakeholder, to be part of that group, so what we've done is also gone out and got stakeholder opinion. We've met with frontline service staff who have day-to-day access, day-to-day contact with the population whose needs we're trying to meet, and we've tried to engage with that population itself through a questionnaire with injecting equipment providers and through focus group work as well. We're bringing all that intelligence together into the short life working group, as well as the evidence base. And actually today's information that's been shared is fantastic, as many members of the short life working group are here today to appraisal and to come up with a model, our preferred model of service for the Glasgow context, which we then present to the integrated joint code for approval or not. As well as that, there's obviously national work going on around the legal framework and around the keeping government briefed of our work that's been done here locally. So we'll take questions on that later on, but thank you very much for your interest.